Hello and welcome to today's webinar, The Great Clinical Decision Support Debate. Today's session will cover the myths and facts surrounding clinical decision support, current clinical decision support trends, the role of clinical decision support with meaningful use, and the clinical decision support tools available within T-System EV. My name is Ann Beatty. I'm T-System Senior Marketing Coordinator, and in just a moment we'll be joined by our presenter. If you have any questions that you would like to submit for the Q&A at the end of the webinar, click on the icon with the question mark and type in your question at any point throughout the webinar. We will gather these questions and try to address as many as time permits at the end of the session. If we don't get to your question, we will follow up with you one-on-one. We will have a recorded version of this session in the event that you want to go back and review the material, or if you want to share the presentation with a colleague who is unable to attend. I will distribute the recording of this event to all attendees. Leading our discussion today is Dr. Bob Hitchcock, CMIO for T-System. His responsibilities include developing strategic solutions for T-System EV, clinical sales support, and business case development. In addition to his responsibilities at T-System, he works as an emergency department physician for Manatee Memorial Hospital and Lakewood Range Medical Center in Bradenton, Florida. And now to kick off our presentation is Dr. Bob Hitchcock.
Thanks, Ann, and good morning or good afternoon to all of you, depending on where you are. Thanks for taking time out of your busy schedules to join us today. We're going to take about half an hour or so and talk about clinical decision support, some of it broadly and some of it specifically to the emergency department as it relates to the care we provide, and some about some of the T-System solutions. We all experience what the impact is on ED resources and the increasing utilization of health care by an ever-expanding aged population requiring greater numbers of resources. We're seeing higher admission rates. We're seeing emergency department visits that have increased by 32% in the last decade, with a 5% reduction in the total number of emergency departments able to care for these folks. And we're not seeing a concomitant increase in inpatient beds, putting an even further strain on the emergency department as ED admission holds go up. All of this leads to a potentially dangerous situation with overcrowding in the emergency departments, longer wait times, leading to significant impacts on patient safety in a negative way, whether it be direct errors from medications or diagnostic errors, or whether it be just delays in care being provided to folks because of the stress and demand on resources. So this leads to the consideration of clinical decision support tools, other things in our armamentarium that can help us provide high quality, safe patient care effectively and efficiently in the emergency department while we're under an ever-increasing stress load. Not everyone is on board, though, with the fact that some clinical decision support tools may be of value. And in fact, there are studies going on looking at individual clinical decision support tools and the idea of clinical decision support more broadly. And I wanted to present some of both sides of the subject to you. The first is a little discussion about folks who are questioning the cost effectiveness of clinical decision support tools. Of course, there are two real reasons to consider a clinical decision support rule for you in your environment, for us in the emergency room. Number one is that it will reduce the overall cost of care. Anything that improves the bottom line is always good financially. And the second is patient outcomes. Do patients actually either get better, or do we prevent them from getting worse? And do we prevent actual errors from happening? And we can have both of these things happening independently and not necessarily leading to the other. So for instance, we can see patient outcomes improve, but that may not be enough to actually make the cost of the tool, implementing it and maintaining it, to make it profitable, if you will, for the hospital to use that tool. So when we look at cost effectiveness, recently there was a study published that looked at a Canadian tool that was it was an outpatient tool used to manage type 2 diabetes. Fairly expensive tool, $160,000 a year, $500,000 or so to implement it. And it turns out it did not yield a positive return on investment, that it was not a financially viable solution, in that it did not generate cost savings. Now, a couple of things. Of course, the Canadian healthcare system is different than the U.S. healthcare system is today, with costs already being dramatically controlled, so that we may not see the same type of effect here in the U.S. with that particular tool. And I am aware that there are several healthcare insurance companies that are actually using tools like this for their case managers, which they are seeing a return on investment. But one of the important parts about this particular study, while it showed that there was no true cost savings, it did show a reduction in some of the significant morbidities or mortalities associated with diabetes, such as reducing amputations, stroke, renal failure, and heart failure. So this was a situation where the patient saw a direct benefit, but the healthcare system or the provider could not recognize true cost savings on the tool. The takeaway from this is that every tool with it has some value, hopefully has some value going to derive. That value is either tangible or intangible, and both are relevant. But know what the value is that you expect to get out of your tool before you put it in your environment. Obviously, for the ED, we're probably not going to look to implement longitudinal type 2 diabetes management type tools. But there are a variety of things that directly relate to the emergency department, such as diagnosis and medication decision support tools, medication monographs, et cetera, things such as UpToDate and other clinical content type items that have a much lower price tag than that $160,000, which the value that brings to the hospital in direct savings from medication errors, et cetera, may far outweigh the cost. But again, it requires you to do a little bit of research into your particular needs and desires and what you expect to get out of these tools. Second group, as we talked about before, either on the cost side or on the patient outcome side, is that recently there have been several articles that said, well, these tools really don't change patient outcomes. And at the same time, not referenced on this screen, but I believe it was the Institute of Medicine, as they looked at the meaningful use rules and the requirement to put in med-allergy interaction checking along with CPOE, they felt that this could absolutely dramatically affect patient outcomes. So I think it's important that we keep in mind every study and every person commenting on clinical decision support tools has a different definition of either what clinical decision support is or is looking at a particular tool that may or may not be relevant to you in your environment. So last month in Archives of Internal Medicine and this month in FEAR CMR, two articles which led the authors to believe that patient outcomes were not truly being affected in a positive way by using these tools. And actually, one went on to say, actually, the monitoring of the patient, the expenditures that actually go into that, and the time that go into it may have actually been increased over not using that tool. And although in that particular study the outcomes were not improved, the patients sure felt awfully good about using the tool. They felt like they could improve their own health, they were involved in their own health care, and that the continuity of care between providers was greatly assisted by utilizing that tool. So again, we've seen some positives in both of these studies which had an overall negative outlook, and this comes down to, again, evaluating tools. What are you going to use them for? What are the expected outcomes, and how do you think they will do in meeting those particular outcomes? Clinical decision support tools, whatever those are, and again, clinical decision support is a fairly wide range of items, whether it be tracking and trending tools, whether it be predictive analysis tools, whether they involve patients and providers, or just one of those inputting information into them, or it's something as simple but as powerful as medication information, drug dosing information, clinical diagnostic decision support, et cetera. These are just tools. It's just technology meant to help automate the way that providers think and what they do and provide them a way to cull through massive amounts of information quickly. But it is just a technology. It's not meant to replace a provider or even supplant a provider. It's meant to be used by that provider in conjunction with that particular patient at that time, given the environment that they're in. The ED, I think, is an ideal setting for looking at specifically targeted clinical decision support tools, and that's because, of course, as you're all aware, our environment is about as hectic as it can get. We deal only in unscheduled visits. and the demands upon us are very large. You've got teams of healthcare providers that are constantly barraged with information that's coming into them, and often having to manage multiple patients simultaneously. The access to tools that can help manage that information and help make the right decision the first time, very valuable to the emergency department. What are some of the things that we know clinical decision support tools can do? The right tools have the opportunity to do. Number one, we know clinical decision support can reduce medication errors. We've seen that clearly with CPOE systems implementing medication med-allergy interaction checking and drug dose evaluation. So particularly in pediatric dosing where you're doing weight-based dosing, or a lot of nursing drips are based upon weight. These types of calculations can be assisted through automation, allowing providers to get the accurate dose at the time the order is written, as well as allowing folks to check that dosing at the time of administration. Prescribing and administration are the two biggest times when medication errors occur in the patient care setting. The ED is the third most common setting in the hospital for medication errors, and most of those are either wrong dose or overdosage. And again, a lot of these have to do with pediatric medications. Shifting a decimal point to the right, just one space, leads to a tenfold increase in the amount of medication administered to a child. That can have drastic and dramatic effects. And while this is completely obvious to almost everybody that simple tools can help these processes, we still see that a large number of our emergency departments are without these types of tools or rely on fragmented information, where the clinician may have a calculator that they're using on their desktop. Nursing may rely on the pump to do some of the calculations for them. Everyone's relying on pharmacy when mixing to get us back the right concentration and the right information about dosing. Whereas putting all those tools in one place for the care team and the ED would really help streamline that process. And we still have a fair number of EDs without any tools to do dosing. Number two, we also know that clinical decision support can reduce misdiagnosis. This has been the goal of having information available in the emergency department, whether it was in a textbook form previously, or a little pocket guide, up through automation today with tools such as Visual DX, Isabel Healthcare. These tools are essentially designed to help providers use information that exists in medical literature and get to a list of potential diagnoses quicker and faster and more accurately than they may be otherwise. And I say that particularly in the emergency department. There's several errors that can occur in the ED, whether you've got an uncommon presentation of a common disease or an uncommon disease. These can sometimes stump a very busy clinical team, where you get to a point in the care where something just doesn't feel right. It's not going the way that it should. Tools can help you step back and say, let me think about this some more. And then with the right tool, with the right data input, you can hopefully get the right information output that helps you change the care delivered. The other big error in the ED is forced cognitive errors, either failing to gather a critical piece of information, failing to understand that piece of information was critical and put it into your thought pattern, or becoming modeled that you've seen this way 3 or 4 times before, therefore this must be X, Y, or Z, and treating that way without recognizing that there may be some intricacies. All this put on top of the hectic, crazy environment in the ED and the incomplete information that we work with on a daily basis makes the ED a very ripe place for tools that can help get to the right diagnosis the first time, prevent admissions that don't need to happen, as well as we're all well aware that the path that we set in the ED as far as the diagnosis and treatment tends to be followed for some period of time on the inpatient side, so that us getting it right will really help the patient in the first several days of their inpatient stay, hopefully get the care that they need as well. Number 3, consistent, reliable information. Of course, there's way too much medical information out there for any person to absorb. We double our knowledge in medicine about every 5 years. And even with Google, you get hundreds of thousands, if not millions of returns on keywords that you may type in looking for search. Not only are you not sure exactly where to go sometimes if you're doing generic searches like that, but you can't be sure that the information you're relying on is truly up to date and is medically authoritative. Just that it exists doesn't make it valuable to you at all. So providing the team the consistent, reliable information where everybody is basically speaking the same language, understands the information in a similar fashion, has that information at their fingertips, and therefore tends to act fairly similarly without having miscommunication errors, things like that. Another thing clinical decision support can do, the right tools, is improve efficiency and throughput. Clearly, it can also have the opposite effect. The wrong tool at the wrong place, or the right tool not implemented in the appropriate places in the workflow or distributed appropriately in the environment that you're in, can actually have a negative effect. Obviously, we don't expect that clinical decision support tools need to be used on every single case all the time. If that's the case, then we're putting an over-reliance on technology and I believe, at least personally, not doing what we do best, which is provide the care we provide. So when evaluating clinical decision support tools for the ED, there are several questions that really kind of need to be asked. And the first is, how is this going to affect and change the way the healthcare team interacts with medical information? Ideally, the tool should be integrated with your EMR systems. It should be presented to the users in the workflow where it's most likely going to be needed. It should be available to everyone all the time. And that information generated by that tool, again, should be consistent and reliable and reproducible across your entire healthcare team. The biggest impact clinical decision support tools may have on the work environment is through alerts. Automating a lot of clinical decision supports, putting numerous alerts in front of providers tends to lead to alert fatigue. You tend to start to ignore alerts when there are just too many out there and it's hard to figure out which ones are truly important, which ones are not. Alert fatigue sets in, and then the tool becomes actually counterproductive or useless. Another very important thing to consider when you're looking at workflow impacts to clinical decision support tools is how does it handle alerting? What things are automated in the background? How is information presented? Is it understandable and useful? And will it not lead to alert fatigue? And lastly, clinical decision support tools or tool suites can give you a single place to access that information. Rather than individual providers perhaps carrying around smartphones with access to what might be something that they license themselves, or a single place to go with a desktop in the ED, et cetera. When you can spread your clinical decision support tools across all of the types of input and output devices you might have in your ED, from whether it's your laptops, your fixed desk stations, your smartphones, tablets, et cetera. Again, integrating it with your EMR and putting a suite of tools in there allows you to have access to all the information that you would likely need to have in the ED, all in one place. So less fragmentation, and also the idea that perhaps as you bundle some of these things together, you can look at technology to actually help you get to that information with things such as single sign-on. Once you're signed on to one, you perhaps signed on to all of them. Or once you're signed into your EMR tool, you don't have to sign again to get this type of information. That information across the board is available to you. Clinical decision support is important enough that even meaningful use, which those of you who know me know that I love my meaningful use. Meaningful use rules do refer directly to clinical decision support. On the vendor side, vendors needed to get certified for stage 1 by implementing clinical decision support rules or rule that deal with patient demographic information such as age and gender, laboratory values, medications, and either diagnoses or past medical history items. On the hospital side, hospitals are required to meet stage 1 meaningful use to implement at least one clinical decision support rule that is relevant to the care that they're providing or to a quality initiative that's happening in that hospital. Stage 2 rules will be out here pretty soon, we believe. The early look at Stage 2, where it looks like meaningful use is going to go with clinical decision support, is integrating it with your EMR, no longer letting it stand alone, and providing for the end user to understand that that information is credible, that it's medically appropriate, and that it is invoked in a way that is appropriate in the workflow. So you're really talking about a tight integration of reliable medical information and put in the workflow for the providers where they need it while trying to minimize alert fatigue. So we're looking forward to those efforts. Of course, the final rules will help tell us what we need to do as a vendor to bring those solutions to you, and we're dedicated to doing that. We're certified for Stage 1, of course, for the clinical decision support rules, but look forward to Stage 2 because I believe we've already made some strides as a company in how we're going to present that and the solutions that we have available. In addition, a little case study. This is with PEPID out of Quebec, Canada. For those of you who are not familiar with PEPID, it's a medical content company with a wide breadth of medical content, things such as medical calculators, drug dosing information, full drug monographs, disease information. They have an emergency department suite which will essentially give the emergency department providers all the information they would need on a regular basis to really help drive care for their patients in the ED. So in Canada, they were trying to solve a problem where they believed that they had about 24,000 preventable deaths for which clinical decision support would have allowed them to recognize a better patient outcome than had happened. They rolled the tool out at 170 EDs, about 2.6 million patients visits a year, in an attempt to both provide information to all the providers as well as standardize that information. What they found was there was about 11 million accesses to the tool in that year on 2.6 million patients, that workflow and productivity were believed to be improved by the healthcare providers. Medical and drug errors were significantly reduced, and adverse events declined as well over that period of time. So for the T-System EV folks, you're probably fairly familiar with a picture on the screen now. Through our integrated web browser as well as through templates, we're providing you access to clinical decision support tools on a subscription basis that you don't need to log into. When you want them, they're there at your fingertips. You can invoke them and get the information that you need. The first is a diagnosis decision support engine called Isabel. That's from Isabel Healthcare. In the background, Isabel Healthcare is continuously monitoring medical literature, both textbooks as well as journal articles. They're looking for associations between symptoms, patient information such as age ranges and gender, and disease processes. The user in T-System would enter demographic information as well as symptomatology, and a list of potential differential diagnoses would be generated with the ability to filter down to those critical diagnoses, the don't missed ones that have a high morbidity or mortality rate if missed. And then in the background, any of those diagnoses, additional information can be gathered by simply clicking on it. It'll take you to several reliable sources of medical information, and it can also be linked to other subscriptions that your facility may currently have with other content subscribers. We can make that directly available to you as well. Here's kind of a review of some of the information that's presented through using the Isabel tool. This is, again, you have age and gender information. You can also refine the search by an area. So if there's been recent travel from an area of the world that perhaps you're not familiar with, you can put that in. It'll help filter out and present diseases appropriately. And you can filter based either on diagnosis, causative drugs, or bioterrorist agents. And then you can add any number of clinical features that you'd like. It does have type ahead and spelling check in there, so it'll help you get things right. There are several states right now that are actually licensing this type of tool and paying for these types of tools, both Visual DX, Isabel Healthcare, and others, because the value that they see in the bioterrorism monitoring potentially, as well as helping to drive healthcare. costs down and outcomes up. Another tool that we've integrated with T-System EV is the PEPID content. We have a variety of content. I'm going to run you through some of that now. The first is we have the full drug monographs from PEPID, so that you can get to any medication in the knowledge base that they have. It will give you all the dosing regimens for adults and pediatrics based upon age or weight or disease, whatever is relevant for that particular medication. You'll also have hepatic and renal dosing adjustments, lactation and pregnancy safety information, cost, trade and brand information, comparative drugs, other drugs in the class, so you can make smart decisions about what medications to either prescribe to go home with or to be administered in the emergency department. And the full drug monograph allows you to get to a dosing calculator, which I'll show you in a minute, but allows you to, at first, also make sure that the dose regimen that you're using is appropriate for that particular patient. So you're basically getting all of your clinical decision support information in one place, as opposed to either multiple places or having to rely on non-automated tools or kind of memory, if you will. Perhaps not choosing the right drug regimen for that particular patient of that disease. There are also hundreds of medical calculators and scoring systems available, both nursing and physician calculators, things such as Braden pressure ulcer scoring system, Krupp scores, asthma severity, of course, NIH stroke scale, Wells for DVT, PE. There's just literally hundreds of them available. And this is all through EV without having to log in at additional time, available either from the drop-down web browser or integrated directly into the templates with links right out to some of these, both to a generic search page for these tools as well as to individual items. So you may see an access to Braden pressure ulcer from the nursing template that will take you directly to that particular calculator in PEPID. So it really helps streamline the workflow. Again, we have drug-specific dosing calculators. Those can be accessed through the drug monographs or directly themselves. It'll give you both weight-based dosing information as well as if you've got IV dose rates, et cetera. It's a great way to both check your dose at the time that you're writing the order as well as the time that you're administering. In addition, PEPID has access to a variety of data sheets, journal articles, evidence-based medicine questions, all in the background, so a wealth of information that's available. In addition, for T-System clients, both paper, electronic, and those using our digital share product, you'll have access to these tools through the T-System client portal. For those of you not familiar with the client portal, I would urge you to go out and take a look. You should all have log-on information. All of our clients have access to this portal. The portal is a great central location for things such as learning management, what's going on, webinar type information, other educational information, product documentation, as well as these clinical tools are available through the client portal as well. If you're a subscriber to either PEPID or Isabel, you'll have access to those tools outside of the EV environment through the client portal so that you can use them outside of the patient care setting in the ED if you require, such as at home, et cetera. The Learning Center, again, contains a variety of information that is relevant. Every time new releases are put out, or we release new training vignettes on a regular basis, telling you how to become more efficient and effective in using the tools, as well as what's new and what's coming down the pike. Product documentation, interactive and very complete. Great place to go with questions about how certain things function. New release notes, obviously, there as well. T-System webinar, press release information, kind of what's happening behind the scenes here at T-System, and some of the things that you can take advantage of, both educational as well as other informative type of presentations. Those will all be on the portal as well. And of course, the clinical decision support area, the clinical tool suite with our Isabel and PEPID tools. You'll also find a variety of clinical decision information that T-System does maintain. That will be available on there as well. It's not demonstrated on the stream, but it will be there. So a variety of other links out to information that can be used in your care in the ED. And with that, I'm going to come to a conclusion of my talks about clinical decision support. I would like to take some questions. If anybody has them in the audience, please use the Q&A box in the WebEx sidebar. Go ahead and submit those. We'll be happy to answer as many as you can submit in the next 28 minutes. While you guys are thinking about your questions that you may have, I want to remind you of the user conference coming up in April, Linked 2012 here in Dallas. Great time of the year. The weather's getting beautiful. It's going to be downtown at the W in Dallas, which is a fantastic location. Registration is currently open, and we have a discounted registration rate through January. I know this month your mind is probably on other things besides getting together for educational and wonderful social environment with all of your friends here at T and other T users. Put a little reminder on your calendar after the first of the year. Get with us, register soon, take advantage of that reduced registration rate. You can find out more information about the upcoming conference on our website, tsystem.com, at Linked 2012. For those who have not been to user conference before, this is a great opportunity. Lots of educational seminars, many of them are actually run by our clients as well. Great opportunity to interact with other T-System users, both EV, paper, et cetera. Talk about things even outside of EV. What are some of the challenges that you're facing in your emergency department? How are other people dealing with it? So it's a great way to network with the community. You'll have the ear of all of the executives here at T-System. You'll have an opportunity to interact with them. And for nurses, we are going to be offering CEU credits again for nursing this year for several of the sessions. So we look forward to seeing you there. We'll be talking about some of the upcoming real critical things to emergency medicine, meaningful use stage 2, ICD-10s, accountable care organizations, all the wonderful pressures that are going to be added on us besides the increasing patient volumes. As Ann stated, we will be sending out a copy of this presentation to everybody that was on today. You can contact Ann or myself with any questions about the presentation. If you have particular questions about the tools, or you'd like to see a demo of some of the things that we offer for clinical decision support, whether it be Isabel or Pepid in more depth, go ahead and contact your client manager. You can send me an email as well, and I'll make sure that gets set up for you. And if you're interested in subscription information, we can hook you up with that as well. We'll let you know that it's much more cost-effective than some of the things that we talked about earlier in this presentation as far as cost goes. So we look forward to hearing from you. I'm seeing right now a paucity of questions. So I will let me go back and reiterate. As far as our solutions for T-System EV, whether it's accessed through the portal or through T-System EV, once you're logged on to one of those two, you will not have to log on to the other solutions. Again, it's kind of a single sign-on thing. They're available to you. There's no impediments. And it's very interactive, but in a friendly fashion. You will not find a variety of alerts showing up on your desktop from these tools. These are more on-demand tools, which helps limit the intrusion, if you will, into your medical care delivery. No additional requirements if you're a T-System user. All that you need to do from a hospital perspective is set up make sure that we can get out to the internet from T-System EV. There's no additional hardware to buy. And it's extremely fast to turn around if you're interested. We can have some of these, we can have Pepid up and running in a matter of a day or two.
Okay, we have our first question. This person's wanting to know the clinical decision support tools. Is the contract with Isabel or is it with T-System?
Excellent question. The answer is that if you don't currently license Pepid or Isabel, the contract would be with T-System. Will be your first line of defense and support in helping with those as well. If you do currently have an institutional license with either PEPIT or Isabel, you can contact us and we will make arrangements to make those tools available to you through T-System EV and through the client portal. So if you're not a current contract, don't have a current contract with these vendors, we will facilitate that. It'll be contracted directly with T-System, and that's that.
Okay, one more question. What version of EV do I need in order to get this functionality?
Okay. Another excellent question, and that's actually kind of a multi-part answer. To get access to PEPIT and Isabel and other clinical decision support tools in the integrated web browser, you need a version of 2.6.3 or later, so 2.6.3, 2.7, or 3.0. As far as linking directly to the templates from to Isabel or to the PEPIT solution, those do require you to be on 3.0 and have the latest content on 3.0, which has those links in there. So you can still take advantage of the clinical decision support tools through the integrated web browser on just about every version that we currently have available, 2.6.3 and greater. And of course, you can have access through the client portal regardless of the version of EV that you're on. All right, in the absence of other questions, we're going to go ahead and let you get back on to the other important things that you had to do today. I want to thank you for your time. It's always great to see lots of our friends attending these webinars. I hope that you're getting something valuable from these. We will be sending out a survey at the end of the conclusion of this. We really do appreciate your feedback. As much honesty as you can give us, we can take. Look forward to seeing you at user conference if you can make it. Please don't hesitate to email us with any questions. Things that come up afterwards, you want more information, go ahead and get a hold of us, and we will make sure that those either get answered or we get you set up to get that information. Thanks again.